Food poisoning and gastroenteritis. Vomiting and diarrhea caused by ingestion of contaminated food or water is a common clinical problem. It is common in travelers to areas where pathogens are endemic, or where food and water hygiene is suboptimal. It can also occur in the UK due to pathogens endemic in the food chain and where preparation and storage of food allows organisms or toxins to persist. Gastrointestinal infections can be caused by viruses, most commonly, bacteria, or their toxins, or protozoa. They present abruptly with diarrhea and/or vomiting and colicky abdominal pain and are usually self-limiting. The commonest causes in the UK are rotavirus, Norwalk agent, Campylobacter, Salmonella, and Escherichia coli. NB. All cases of food poisoning are notifiable by law. NB. Stool cultures often fail to grow an organism. Etiology, pathophysiology, and pathology. Causes of food poisoning and gastroenteritis are shown in Table 37. Enterotoxins are usually secreted bacterial proteins that act on the intestinal epithelium, or are absorbed into the bloodstream and have systemic effects, e.g. vibrios, and enterotoxigenic E. coli toxins can stimulate intestinal secretion. Enteropathogenic bacteria such as E. coli, Campylobacter, Salmonella, and Shigella species invade the epithelium, causing ulceration and inflammation. The stool contains blood and leukocytes, and there is a systemic inflammatory response resembling inflammatory bowel disease. Epidemiology. Worldwide outbreaks, although poorer parts of the world have higher rates of endemic infection. Clinical presentation. Vomiting and diarrhea following exposure are the typical features. The main danger of acute gastroenteritis is dehydration and its consequences, which can include life-threatening circulatory collapse, especially in children and in the old and infirm. Physical signs. Dehydration is the most likely sign. Rectal examination may reveal inflammation and bleeding, particularly if sigmoidoscopy is performed. Investigation. Stool and vomitus should be collected and analyzed for pathogens by microscopy, culture, and toxin testing. Food poisoning is a notifiable illness, for obvious public health reasons. Treatment. Emergency. Dehydration and electrolyte abnormalities should be corrected. In acute gastroenteritis, antibiotics have little role, although they may reduce the duration of illness in cases of dysentery. Complications. Reactive arthritis may develop after a self-limited episode of food poisoning. Guillain-Barré syndrome may follow infection with Campylobacter species. Prevention. Food hygiene and meticulous cooking of potentially contaminated meat and poultry are the key measures. Bacterial dysentery. Etiology, pathophysiology, and pathology. Infection is spread by consuming contaminated water or food, particularly meat and poultry. Common causes of bacterial dysentery are Campylobacter jejuni, Salmonella species, Shigella species, and enteropathogenic E. coli strains. Epidemiology. Travelers to endemic areas in the tropics, subtropics, and poor countries with inadequate sanitation and food hygiene practices are most affected. Salmonella infection is endemic in poultry in the UK, and undercooked or raw eggs and chicken are a common cause of infection. E. coli strain 0157H7 is endemic in cattle and causes outbreaks associated with ingestion of contaminated beef. NB. Bacterial dysentery is not only a disease of travelers. Salmonella infection is endemic in poultry in the UK and can contaminate the food chain. Clinical presentation. The incubation period is 3-5 days. Dysentery typically causes severe, cramping abdominal pain and diarrhea, which may be bloody. There is frequently associated malaise, headache, and myalgia. Infection with E. coli strain 0157H7 may be associated with severe renal dysfunction and hemolysis, and may be rapidly fatal. Bacterial dysentery may be indistinguishable from idiopathic inflammatory bowel disease, IBD, and may occur in patients who already have a diagnosis of IBD. NB. Sigmoidoscopic and histological appearances in gastrointestinal infections and idiopathic IBD may be indistinguishable, and the two conditions can also coexist. Complications. Bacterial dysentery may cause Reiter's syndrome, uveitis or conjunctivitis, urethritis, and arthritis. Guillain-Barré syndrome may follow infection with Campylobacter species. Salmonella infection may become systemic, e.g. causing osteomyelitis or septic arthritis, and a chronic carrier state associated with colonization of the biliary tree is sometimes established. NB. Infection with E. coli strain 0157H7 can follow ingestion of contaminated food, especially beef, and is associated with a severe life-threatening hemolytic uremic syndrome. Treatment. Fluoroquinolones such as ciprofloxacin are usually highly effective. Hemolytic uremic syndrome caused by E. coli 0157H7 infection requires high-intensity supportive treatment. Antibiotic-associated diarrhea. Etiology, pathophysiology, and pathology. Use of antibiotics alters the enteric bacterial population and frequently causes diarrhea. In some cases this is caused by overgrowth of enterotoxin-producing Clostridium difficile. Most antibiotics are implicated, including clindamycin, with the widespread use of third-generation cephalosporins and broad-spectrum penicillins responsible for many cases. Clinical presentation. Diarrhea may be mild, with frequent watery stools, or more severe, with passage of blood and mucus and a marked systemic inflammatory response, fever, tachycardia, hypotension. The most severe consequence of toxigenic C. difficile infection, pseudomembranous colitis, may lead to intestinal perforation and is life-threatening. Investigations. C. difficile can be cultured from the stool and its enterotoxins can be detected by a sensitive and rapid enzyme-linked immunosorbent assay, ELISA. Sigmoidoscopy reveals punctate yellow-white plaques adhering to inflamed mucosa in pseudomembranous colitis. NB. C. difficile enterotoxin can be detected by a rapid and specific ELISA performed on stool specimens. Prevention and treatment. Strategies to minimize the use of broad-spectrum antibiotics reduce the incidence of C. difficile infection. First-line treatment is with metronidazole, administered orally or parenterally. Relapse is common, up to 30%, and can be treated by vancomycin 125 mg QDS orally. Probiotics may reduce the incidence of further relapses. Parasitic infestations of the intestine. Etiology, pathophysiology, and pathology. Intestinal parasitic infestations are widespread throughout the world. In the UK the commonest infestations are with Giardia intestinalis and Enterobius vermicularis, pinworm. Hookworm and roundworm infections may cause chronic diarrhea, malabsorption, growth retardation, and intestinal blood loss. NB. Infection with Giardia intestinalis and Enterobius vermicularis are widespread in the UK. Clinical presentation. Giardiasis is spread by the fecal-oral route and by ingesting contaminated water. The organism is relatively resistant to chlorine. Infection typically causes nausea and diarrhea with excessive flatus after an incubation period of 1-4 weeks. Malabsorption may occur, with pale, bulky, offensive stools and weight loss. Symptoms may persist for months. Pinworm infection is spread by the fecal-oral route from human to human. It is particularly prevalent among children and may cause perianal pruritus as the organisms and eggs are shed. Investigations. Giardiasis is diagnosed by finding trophozoites in jejunal aspirates or biopsies taken at endoscopy, or cysts in the stool. Pinworms or oocytes might be detected in the stool. Treatment. Metronidazole or tinidazole are highly effective for giardiasis, while pinworm infections are treated with mebendazole or albendazole. Household contacts should be treated. Intestinal and liver amoebiases. Etiology, pathophysiology, and pathology. Entamoeba histolytica is a free-living protozoan that spreads via person-to-person contact and by ingestion of contaminated water or food. It can cause dysentery when localized to the large intestine. The organisms are distributed hematogenously to distant organs, particularly the liver, where they may cause inflammatory masses, amoeboma, and abscesses. Clinical presentation. The incubation period for amoebic dysentery is 1-4 weeks. Symptoms range from mild diarrhea to severe bloody diarrhea, colonic ulceration. Amoebic liver abscess may present many months after infection with abdominal pain, fever, and abnormal liver function tests. Investigations. Dysentery is diagnosed by examination of the stool, which may demonstrate live parasites, or by rectal biopsy or serology. Amoebic abscesses are visualized by imaging, such as ultrasound, and may require aspiration and microscopy. Complications. Liver abscesses occur in 1-3% of cases. Treatment. Metronidazole is effective in treating amoebic dysentery. Liver abscesses should be treated with metronidazole followed by diloxanide to eliminate carriage of the organism. Intestinal features of HIV infection. Despite progress in treating HIV infection, infection rates are increasing worldwide as well as in the UK. Up to 1/3 of HIV-positive individuals in the UK may be unaware of their infected status. Untreated HIV progresses to cause a profound immune deficiency, and with immunodeficiency the gastrointestinal tract may be involved by oropharyngeal and esophageal candidiasis, cryptosporidiosis, microsporidiosis, atypical mycobacterial infection, tuberculosis, cytomegalovirus, and herpes virus infections. HIV-positive patients may also be at greater risk of enteric pathogens such as amoebiases and dysentery-causing bacteria. NB. Gastroenteritis caused by unusual organisms, oropharyngeal candidiasis, and severe and persistent herpes virus infection raises the possibility of HIV infection. HIV infection itself may cause an enteropathy, manifest as diarrhea, malabsorption, and weight loss, which histologically has the appearance of partial villus atrophy with crypt hyperplasia and polymorph infiltration. Depletion of lymphocytes in the gastrointestinal tract is an early feature of HIV infection, and in patients on antiretroviral drug treatment a reservoir of latent virus may persist in gastrointestinal lymphoid tissue. CO infection with HIV and hepatitis C or B viruses causes more severe and rapidly progressive liver disease. Antiretroviral drug treatment may cause severe drug-induced hepatitis, hence, for instance, Nevirapine should not be used in individuals with a high or normal CD4 count because it can induce a life-threatening hepatitis. NB. HIV in the liver. Chronic viral hepatitis is usually more severe in the presence of HIV-CO infection. Antiretroviral drug treatment may cause severe liver disease.